Top Med Talk.
Today's Top Med Talk is a two-part piece. This is part 2 and part 1 has already been released. Please check out the show notes for more details.
Thank you very much. So, Scarlett, I have a proposal because we've got 43 questions have accumulated now, is that I articulate them and I leave you to chair the answering of them in as quick fire fashion as possible, if that's okay with you.
Perfect. Different.
First one is from Essam. How can we integrate frailty and cognitive scores in risk assessment tool to facilitate inclusion in shared decision making?
Jude, do you want to take that?
So I think we need to remember why we're doing tools and what the purpose of them is. And some tools are designed to screen for a problem so that we don't clog up clinics with patients who don't need to be seen, then completing long questionnaires. And of course, some tools are more of a surrogate for a diagnosis. So I think we need to think about what the purpose of the tool is first. And as we've talked about pathways, is screening early in the pathway for problems that need to go to a specialist in that problem is a good way to go. The way we operate things at Guy's and St Thomas's is that we have referral criteria that surgeons, sometimes anaesthetists, sometimes preoperative assessment nurses, sometimes GPs send patients to us. And then we assess frailty in every patient who we see in our clinic. We do use the Edmonton Frail Scale and the CFS, but CGA is essentially the gold standard for appraising frailty. And we do cognitively assess our patients. So we also use the clocks from the EFS as a screen, although the literature for doing that is not supportive, but the patients have already completed it as part of their frailty score. And then we do a mocker as a brief cognitive assessment tool. And within all the studies we've done within the department, it takes about 8 minutes to do a mocker. It's done sometimes by us, sometimes by nursing colleagues, and sometimes by our therapist. So we've embedded that into our high-risk clinic so that we have those scores on all patients. It's important to remember as well when we're talking about tools that has to be taken in the context of your clinical impression of the patient. And we have good data looking at mocker scores in surgical groups now. It doesn't constitute a diagnosis of dementia, but it certainly infers risk for that patient of delirium.
So next up is Nick Parry. We have a one-stop process in Dudley where we pre-op assess early. But how can we improve surgical colleagues' ability to identify frailty, etc., to support this?
Vicky, do you have any answers from across the pond?
Actually, I wish I did. I think that our UK partners are actually a lot more well versed in this. It is something that we do struggle with. We probably started assessing for frailty in the last 3 years, and it's not where it needs to be at all. So I probably think that I would defer to either Jude or Daniel on that, just because we are still learning, and I wish I had some great answers, but I don't on that.
Okay. Daniel, do you have? Yep.
Yeah. So briefly, we've spoken to surgeons about when we set up our frailty service, and some are enthusiastic and some are kind of a little bit less so. But what we found was that just in part of the nursing pre-op assessment, because they ask a lot of questions about a person's home life. It's all very relevant to what's going to happen to them. And by they finished a nursing pre-op assessment, they were able to pretty accurately complete a clinical frailty scale. It was all there. So rather than going through the surgeons, we just found that the nurses were really good at picking up those pieces of information that you need to know to understand frailty.
And Jude, can I comment that you had a tool that's used in general practice to score frailty? Can you expand on that a little?
So the Electronic Frailty Index, which is commissioned in quite a lot of areas in the United Kingdom now. So there will be patients referred in from primary care who have an EFI attached to their GP printout or referral letter, which could then be interpreted, if it's noted, by the team that received the patient. But I think we do know from our national frailty networks, both the specialised clinical frailty network and the acute network, that CFS is doable and feasible for people from all backgrounds. And I think certainly from work in Australia, it's actually getting embedded with surgeons doing it as well. So there's lots of ways to kind of address the issue of people not wanting to do it or not being skilled to do it.
Most patients will have an operation sometime in their life. should surgical school be renamed and moved to being a wellbeing clinic and offered to all patients?
We run a surgery school in Manchester. One thing that, this is certainly the case, it is all about well-being. And in fact, when it's attended by patients' relatives, I always make the point, and so do our colleagues, that this applies as much to me and to you as it does to the person who's about to have the surgery. And it is, and Stenny already mentioned, it's a teachable moment, so you definitely have people's attention. And that's a really important moment, and that's why surgery school seems to work. I mean, we've just moved our surgery school to a kind of virtual enterprise because of COVID. We didn't want everybody sat in the same room, obviously. So, and that works too. So I think that there's a lot to be said for surgery school, but I wouldn't say it should just be a wellbeing clinic. I think we have to, that people want to know about their surgery. Even though sometimes some of the patients invited to surgery school don't end up getting surgery, it's still part of that shared decision making, in that you're explaining to people, this is what happens to you when you have surgery, this is what post-operative care looks like. But having said that, we're expanding surgery school to people who might be embarking upon chemo. So there is some merit in the principles of surgery school in terms of not just for surgical interventions.
We do have a wellness clinic, we call it, in all of our hospitals. And really the patients, all of our enhanced recovery patients, every single one of them do go through the wellness clinic, whether that be just for to see a nurse for education, for screening, whether they're seeing a PA or a nurse practitioner, or if they need higher level of care and seeing one of the anesthesiologists. But within that wellness clinic, we go through very intricate patient education, what to expect from the moment you walk into the hospital, their entire perioperative journey, and talking about pain expectations, what we're going to do for their pain, what types of anesthesia we're going to be using, if we're using regional, what have you, just all of the things that they need to expect. And we found that the patients, even before we implemented the entire pathway for enhanced recovery, just getting them well educated and having them know what to expect improved their outcome. They did much better. And then once we implemented the entire pathway, the outcomes were even more pronounced. But the wellness clinic in of itself, we had one and decided to expand on that. And now we have 7 different wellness clinics so that patients getting operated on in all of the hospitals are seen in the wellness clinic. I wish we could do that for every single surgical patient, but we do that for every enhanced recovery surgical patient right now.
Could I just add, Scarlett? One of the we run a surgery school in Southampton, and as Danny has said, trying to do this online and by telephone at the minute. One of the important elements with the face-to-face education is who we are reaching. We've just analysed our first 800 patients or so, and interestingly, the people that turn up to surgery school tend to be, there are factors that affect whether or not you come. And I just think we need to remember that sometimes the hardest to reach patients with the greatest needs tend not to turn up to things that are voluntary, because of transport, so there was distance, and the other thing was socioeconomic deprivation was associated with non-attendance. And the other group of patients was non-cancer patients. So cancer patients were much more likely to turn up to our surgery school than, say, our vascular surgery or our orthopedic patients, interestingly. So I just think we need to, when we design these programs, we need to think about the most needy populations and involve patients in the design of what they think would be the best way to ensure that they might engage. So engagement from the high needs group is important.
That's very, very helpful. And I'm hopeful that the kind of move towards more people using virtual resources will be helpful. Hopefully we can reduce the health inequalities. If everybody's using an iPad to contact their neighbours at this time, or we can use those resources to get surgery school messages to more people. But Dan, Monty, more questions, thanks.
The number of screening tools are overwhelming for all 3 aspects.
Yes.
Which would you recommend if only minimal time or money was available in stretched services, which I think is a fact for most healthcare systems, that minimal time and money is available. So, screening tools.
Jude, you had quite a lot on that in your talk.
So, so I think, again, purpose of screening and who is your population. So to be clear about frailty, CFS for screening and then a comprehensive assessment for diagnosis, which can be then bolstered by the EFI or the EFS. For
Could you explain the abbreviations? Sorry, please, Jude. We keep getting told off
EFS,
about abbreviating.
Sorry. Edmonton Frailty Scale or the Electronic Frailty Index. So the Electronic Frailty Index is the GP one, and the EFS is a very quick tick box that you can do within a clinic setting in about 3 minutes. I think with function, again, lots of these tools are developed in specific populations, so it very much depends. So we've used the Bartel over the years in our clinic and found a huge ceiling effect in preoperative patients, and so have discontinued it. And we use a different tool within our setting called the Nottingham Extended Activities of Daily Living, which is a functional score actually originally derived in stroke. There are hundreds of them. So I think that the thing to do is to look at your population. They can be self-completed. And so we find in a mixed preoperative setting, so of all specialty patients, cancer, non-cancer, that the needle works very well because of a big ceiling effect on Bartel.
Brilliant. And Daniel, any recommendations for screening?
Well, so again, it's sort of featured in my talk quite a bit, but I would say, as already described, the Rockwood Clinical Frailty Scale is probably becoming a standard. It's got significant flaws and is quite open to interpretation, but often it's done pretty well in my experience. In terms of cognitive screen, if it's a quick screen, we've been using Minicog. Minicog is really quick because it's remembering 3 words and drawing a clock face. And that can usually pick up quite a bit, some cognitive impairment, and has been shown to work in perioperative practice. I would although the data hasn't come out yet, I think it'd be very interesting to see from the WHO DAS version 2, which is being used in PQIP, because PQIP have recruited many thousands of patients now, and the HUDAS-2 score has been used preoperatively and then at 6 and 12 months. And so, and obviously that it's also measuring perioperative complications. So and the advantage with HUDAS is that pretty much anybody can do it, and also it can be done over the phone as well. So I would start with those 3 tools in terms of function and frailty. I'm not going to go into the sort of aerobic fitness. I'll let Denny say what screening tools should use for that.
I completely agree with the tools that have just been alluded to. I think if you're short of time, the clinical frailty scale, and for the first assessment of physical activity fitness, the Duke Activity Status Index, and hopefully there'll be some more data about its precision shortly. And for nutrition, either the PGSA, which is the patient-generated subjective assessment, or the perioperative nutrition score from the POCI collaborative. That takes about 3 minutes. And the advantage of the second of those, so the DARSI and the perioperative nutrition score, the patient can fill those out themselves. So you don't have to use your time in clinic. So while they're waiting to see you, or in fact, ideally, when they're either referred from general practice or at the point of referral, you can send them those questionnaires to complete. I think that's a really important point. There's a lot of questionnaires, and it takes a lot of time out of clinic if you can actually get that data done before they come into the room and have a quick look at it.
So Joanne Bell, hi Joanne. I sometimes wonder if what we're doing in pre-op assessment is actually public health and GP screening, which should be being done for everyone.
Brilliant. I completely agree. I'm just going to do was lead author for this 5 years ago, Exercise the Miracle Cure, and the role of the doctor in promoting it. And actually, this is what, it's about exercise, nutrition, medication review, psychological preparedness, understanding health literacy, risk, benefits, alternatives, what's your life all about. It's all that sort of thing. That actually, it's medicine, isn't it? And we've just carved everything off into specialties, and we think that the technical aspects are the important bits because they're what no one else does. But that's just me. Who else wants to have a view?
I completely agree that everybody should have this. But equally, I don't think sometimes people say this is primary care's job. I don't think that's a helpful approach. I think we need to work in an integrated fashion between primary and secondary care. That's going to become increasingly important because although we all need to improve our exercise activity for the rest of our lives, there is also an event about to happen for a surgical patient where we're fortunate enough to know that a surgeon's going to approach them with a big knife and cause potential harm. Sorry. But, and so then we have a short period of time where we need maybe an intense intervention that we need to be followed up so that they maintain that behaviour in primary care. But it's not just primary care's job in the same way it's not just our job. And we need to be able to move the patient from hospital back to dietitian or weight loss support services in the community, and the same with psychological support, etc. So I think it's all of our jobs to talk to patients about healthcare behaviours, and I think that's what the Making Every Contact Count campaign is all about.
So, Scarlett, I'm going to dive straight in there because it overlaps with the next question, which is once a patient is listed for surgery, what is the best time for an anaesthetist to get involved? Given the fact that waiting lists are up to 18 months for elective surgery. Now, I thought those days had gone, but there we go.
Well, the waiting lists are going up and up as we're struggling with a post-pandemic service recovery. I like Denny's idea that our pathways are really clinician-focused rather than patient-focused. And my view is if we can get the pathway right with, say, anaesthetic input right at an early stage or perioperative medicine concepts in at an early stage, then it's cheating a bit, but we haven't got enough anaesthetists to go around. And my view is you get the concepts in early and then pick off the people that need very intensive anaesthetic input from the moment they really seem to be heading towards an operative option. So that's my answer. Anyone else?
We don't have the wait times that you all have. I'm trying to get our surgeons to hold off on surgery a little bit longer instead of bringing people in so quickly so that we do have time to optimize them. But I think the simple answer is as early as possible. And like you said, Scarlett, that, some patients are going to need more in-depth information, intervention from the anesthesiologist and the anesthesia team. And if we can get them in as early as possible and get the ball rolling, the patient will benefit obviously on the back end of that. We pretty much have about maybe a 2 to 3 week time frame wait period. So we try to get them in as early as possible.
Can someone highlight the differences between fitness, functional capacity, frailty, and sarcopenia? It seems there's overlap with very similar interventions.
Well, I'm happy to. So your conclusion there is exactly right. There is a lot of overlap. Even if you look at definitions of functional capacity, so the cardiology definition of functional capacity is VO2 max, which is a fitness measure. The occupational therapist definition of functional capacity is what you can do functionally. Frailty, as Jude described beautifully in her talk, is a situation of reduced physiological reserve that happens increasingly with age, but not in all elderly people with comorbidity, but not everybody with comorbidity has frailty, and it has a functional element as well. So the result of that reduced physiological reserve is often that you have reduced functional capacity. And sarcopenia is another subset of those. So some of the people who have reduced function, the reason for that, or the association with that, is that they have reduced skeletal muscle mass, and that's what the definition of sarcopenia is. And there are plenty of Venn diagrams where all of those overlap. So you can be frail without being unfit. You can be unfit and frail, or just unfit because you've not done anything for a long time and sat and surfed your couch. And there's plenty of people. Or you can be unfit because you've got comorbidities that have impacted your ability to exercise, like chronic lung disease. You may have ventilatory limitation to what you can do. So they are all overlapping. And I would agree with the other point that one of the intervention is certainly not, Jude has clearly alluded that the CGA is about personalized, individualized optimization, but one of the elements of that is to assess their functional unfitness by exercise training if it's appropriate. So many of them will have the same interventions, and that's why trying to do a risk score and treating these things as separate things I don't think is very helpful. You just need to screen and then direct the person to the right thing. But most, exercise as an intervention in frailty, in not terribly high quality studies, has been shown to be effective. It's been shown to be effective preoperatively. And indeed, as Danny alluded to, occupational therapists and physiotherapists have been giving people exercises to improve their functional capacity for years. So we are slightly reinventing things that have been around, and we're just looking at them from a slightly different context.
This is from Graham Walker. In mild cognitive impairment, should we tell patient that it will worsen post-op and not be expected to fully recover?
Daniel, do you want to take that?
I think it's worth telling the patient what they've scored, what they've scored and what that might mean, because often that's news to them. And if they're with somebody, it might be news to them too. You don't know for sure that it won't recover, and I don't think that's necessarily true. And I think there's always a risk of having cognitive deficit following and even if your cognitive function was okay beforehand. So that probably should be part of the informed consent process. I would say the thing that I would be more interested in talking about with a patient are strategies to particularly reduce the risk of delirium following surgery in somebody who has mild cognitive impairment. And some of that is obviously related to the type of anaesthetic and the type of surgery and the length of surgery and other factors that the patient has little control over. But there are other factors that they maybe can help. So they may want to make sure that when they come into hospital, they've got their hearing aids and their glasses and things like that to maintain orientation. It's probably worth letting family know, because the support of family can help if a person becomes delirious. So I think it's something that you'd want to discuss with the patient, but I don't think you'd say, oh, well, you've got some mild cognitive impairment and it's likely to get a bit worse after surgery, because that, even if that's true, it may just be temporary. And I don't think we really know enough about that to say definitively that this is a big risk.
Next up is, what strategies have you found most helpful in engaging surgeons with identifying their frail patients? Now, I thought to add to this, I thought in some systems there's a sort of tariff loading if the patient's identified but as frail, and or there's an outcomes evaluation adjustment according to frail patients. So there we go, strategies to engage surgeons.
Jude, have you got some experience of that?
So I think we're in a privileged position now at GSTT in that we have a very engaged surgical workforce, and we receive referrals from all surgical subspecialties now. Very much often talking a common language. So patients will be referred as they are frail or they have cognitive impairment, which was not the case sort of 10, 15 years ago. So I think we're in that privileged position now. We certainly weren't at the start. And there were lots of different strategies we took to try and engage our surgical colleagues in identifying these things and sending them up so that we could then impact on outcomes. And so very much finding out what were the things that were bothering the surgeons, or particularly the service managers in those areas. So was it length of stay? Was it not being able to get enough elective orthopaedic patients through in order to have good turnover? Was it same-day cancellation? What was it that was the things that were being discussed in those meetings that meant they wanted us to be involved? And so using those things as drivers to then get patients referred up to our service.
I think that's brilliant. From a surgeon, data is really helpful, particularly on complications, because surgeons hate those, and then all the other service-related things that people can understand, cancellations on the day and so forth, and trying to get to present at surgical clinical governance meetings so that they're not separate from anaesthetic meetings. So all great ideas. Thank you. Monty.
Next, from David Raw, there seems to be a national shortage of geriatricians. And for this question, we're going to take the nation as England, perhaps pan-UK, of geriatricians to resource POPs type models of care. Is this workforce issue being addressed? I certainly say, from previously being the lead for the development of perioperative medicine at the Royal College of Anaesthetists, in our inaugural document, we co-wrote the fact that this was a very high priority to bolster the number of geriatricians in the National Health Service. I'd be interested to hear what it's like in the United States as well.
In the United States, we are seeing an increasing number of geriatricians. which is fantastic. And I know when I went to school to get my doctorate, mine is actually in adult and geriatric for nurse practitioners. So we have a very focused geriatric population for advanced practice clinicians to better understand that population. But we probably 5 years ago weren't really seeing geriatricians in the field so much, and we weren't involving them in the perioperative management of our patients. But in the last few years, we definitely have seen an increase in our area. And when I speak to colleagues around the country, I'm hearing the same sentiment.
Yeah, so from the UK perspective, of course, we do have a workforce gap. It is being addressed through training numbers and also through changes to more junior medical training as well. But that gap will still remain and, of course, be there for many years. The two main issues are that we are also pulled into lots of other areas other than just surgery. So front door medicine and care home medicine and community medicine, plus all the acute take medicine that geriatricians do. But I do think there's a lot that can be done and a lot that we've modelled within the POP service on using nurse practitioners to take some of the slack when you don't have enough consultant geriatricians in order to then try and fill those gaps. And so we try to do that through training up our foundation doctors, through the foundation program we have here, through out-of-program specialist registrar training and through specialist nurse training in conjunction with the RCN. I think Jason's spoken about that in another session as well.
Yeah. Scarlett, we have time, I think, for one very directed question before we ask you to close this session. It's to Daniel. What has your experience been in advising and achieving physical fitness in patients who present to surgery with persistent pain that can be a limitation?
That's a good question. Obviously, we have a pain service based in our hospital, and we've developed a system of improving people's physical fitness by working with local gyms, local leisure centres that are run or funded through local authorities. And so what we've been able to do is get involved in those more localised areas so people can go to their gym locally, and that seems to have worked for them. I think in context of pain, what we've had to do for some patients is refer them to the pain clinic. It's more for the patients who have a longer wait. So say for orthopaedic surgery, is probably the best example. I don't think there's much you can do for people about to have cancer surgery in that 2-week period to try and get on top of their pain, or the 3-week period and get on top of their pain and then encourage exercise. But for the orthopaedic group, we have been doing things like injections, radiofrequency ablation, and then encouraging patients to exercise after that. And I think that can work, but I'd say it's a bit more tricky when you're on a very tight timeline to get all the ducks lined up.
Can I just recommend there's some resources on the Versus Arthritis and British Orthopaedic Association website for pain management for people, particularly people who are on waiting lists now during the pandemic to improve their pain. So I recommend those. And the Chartered Society of Physiotherapists have the same information. So I think that's all we've got time for this session. It's been really, really interesting, and it's sparked all sorts of more thoughts and ideas going forward. And this is the future, really, with our populations around the world. It's fitness, frailty and function is really the answer for patients and what we need to do to try and get them better. Thank you very much for watching.
Top Med Talk.
Thanks for listening to Top Med Talk. We are excited to announce the World Congress of Perioperative Medicine happening in London this year. Check it out at ebpom.org. It will take you through to our carbon-free conference center where it has the EBPOM platform. You can find more information. Be sure to subscribe to Top Med Talk and EBPOM at ebpom.org.